All righty, hello everybody. We're going to give just a few more minutes here, and then we'll get started. We're just going to let a few more folks join us, and then we'll get going. All righty, in the interest of time, we'll go ahead and get started here. This is being recorded, so anybody that misses out can join us later. So I'm David Moore, one of the urologic surgeons at Deaconess. Thanks for joining us on this webinar about prostate cancer survivorship. I do talk a lot about this on my website, so you can always visit moreurology.com to learn a little bit more about some of the things that we're going to talk about tonight. So just a little bit about me. I'm from Evansville. You know, I'm a longtime member of this community and have a lot of friends that are actually my patients. I then went to DePaul for my undergraduate degree, and then down to Nashville for almost a decade to get my medical degree from Vanderbilt, and then I stayed there for 5 years for a urologic surgery residency. Had a great training experience there. It's one of the top training programs in the country. And then in 2018, came back home to Evansville. Got all my family here. So I like to tell patients I'm not going anywhere. I'm here for the long haul. No relevant disclosures. That just means that I'm not getting paid to give this talk. I don't have any interest or financial interest in any device companies or anything like that. Nothing. No conflicts of interest. So tonight's agenda, we're going to talk about prostate cancer. You know, how common is it? Obviously, y'all are here because of that. What it's like to live with prostate cancer. We're going to talk a lot about some of the side effects of prostate cancer treatments, what to do about it, and then what treatment options there are available for some of those prostate cancer related side effects. So just again, a bit of an overview about the prostate. That's that gland that sits between the urethra and the bladder. Its job is to make most of the components of semen. That's the purpose. But as you know, it can have various problems occur with the prostate as men get older. It can get infected or inflamed. That's prostatitis. Prostate cancer, of course, that's what we're talking about. That's the most common cancer. It can also grow and get larger as you get older and cause all those bothersome urinary symptoms like weak stream, stopping and starting. And you can have all three of these, not usually simultaneously, but you can experience all three of these at different points in your life. And having one of them, like a large prostate, does not necessarily mean that you'll develop prostate cancer. So how common is prostate cancer? Well, very common. It's the most common cancer in men. This is from 2023. You can see it's this second leading cause of cancer-related deaths in men. So a full 40% of men with new cancer diagnosis in a year are going to have a urologic cancer, the kidney, the bladder, the prostate. So that's why so much of what I do is urologic cancer and cancer surgery. Just to touch briefly on how to prevent prostate cancer. You don't necessarily prevent it. You can reduce your risk by a healthy diet and exercise. We'll touch a little bit on that later. But the key to prevention is preventing advanced prostate cancer. That's how prostate cancer will kill you, is when it is advanced, it spreads to lymph nodes and bones and other things. So we've got screening for prostate cancer to catch it in earlier stages when it's treatable and curable. So we know that 1 in 7 men will get prostate cancer, and by screening with a simple blood test, we can reduce that risk of metastasis, of it spreading. We can reduce the risk of death from prostate cancer. And so we always want to screen most men, you know, from the age of 55 to 75. And then we'll screen earlier in African-American men or men with a family history, brothers, fathers with prostate cancer. We'll screen earlier and then even later in life as well. So just kind of some take homes for all of your friends and family members about prostate cancer screening. That's that once a year blood test. You want to, any man aged 55 to 75, and then at-risk men, family history, African-American men, you want to target earlier screening. That's just once a year. And if you really see any PSA above 3, get it confirmed by a second measurement. And then you need to see your urologist. I'd be happy to see you for that, to talk about what, if anything, we need to do next. We're not necessarily going to react right away, but we need to have that conversation. So I'm going to jump ahead now to assuming that you have a diagnosis of prostate cancer, or you're tuning in because you have a loved one or a friend with a diagnosis of prostate cancer. And that is confusing as all get out, because there's so much information that you're going to be exposed to, both in print and online, and your clinic appointments, just overloaded with information. And there's discussions about so many side effects. But what I want to touch on for sure is that this prostate cancer, in general, is quite treatable and quite curable. Even in its advanced stages, you can live with prostate cancer. And currently, there's about 3 million men in the US that are prostate cancer survivors. So it's incredibly common. You're going to have friends and family that have gone through this. You want to first, assemble your team. You certainly want to get an experienced urologic surgeon. So someone who has experience treating lots of prostate cancer, all the different stages, someone who has experience surgically treating prostate cancer. That's who you want on your team. Always good to see a radiation oncologist, to have a consult with them, particularly if you're going to choose radiation as a treatment option. You're definitely going to have an intimate relationship with the radiation oncologist, but always good to have a consultation with them. We'll send folks to medical oncologists for advanced prostate cancer. So really high risk prostate cancer, when it's spread to lymph nodes or other places, you'll have a medical oncologist on your team. We'll often send folks to genetic counseling if you have a very strong family history or other cancers in your own history. Certainly physical therapists, we'll talk about that, very important to have on your team. And then definitely social support. So friends and family members come to appointments, learn as much as they can about it. There's support groups online. That's a link to the Prostate Cancer Foundation, where you can find various support groups. Even places like Facebook have, prostate cancer support groups. So when we diagnose people with prostate cancer, they can often be diagnosed almost 30% of the time with low risk prostate cancer. And that's where we look you in the eye and tell you have cancer, but that we're just going to monitor it. Because active surveillance truly is the standard of care for low risk prostate cancer. That means you have this diagnosis, it's been confirmed, low risk. We're not actively treating it because we know low risk prostate cancer has not been shown to harm you or decrease your life expectancy. The risk is that it becomes one of the higher, the riskier cancers, or that we don't follow it closely enough, and it does during that time. Because all the treatments can have side effects, the goal of active surveillance is just to delay those treatments for as long as we can. And this is very anxiety provoking. Understandably, you get a diagnosis of cancer and we're just going to monitor it. And so I just like to reassure patients that's so important that we do this, because it's the right thing. And we shouldn't treat just fear over the cancer or anxiety about the cancer with one of these radical treatment options if it's not going to harm you. But there's certainly a possibility that it could. And so active surveillance is very active. We're checking your PSAs twice a year. We see you every 6 months. We always do a confirmatory biopsy after that initial biopsy. We'll do periodic MRIs of your prostate, and we'll see you very regularly doing repeat biopsies, usually every 1 to 5 years, looking for progression or signs that we need to take somebody off of active surveillance. So the biggest thing you can do if you're living with a diagnosis of low risk prostate cancer is just to follow up on schedule, because people run into trouble if they miss appointments for a year or more, and then that's when that prostate cancer can change without us catching it in time. So then let's assume that you have an intermediate or a high risk prostate cancer, but it's localized to the pelvis. And so in that scenario, radiation is certainly going to be a very viable treatment option. We're not going to get into a detailed discussion about whether or not to choose radiation or surgery for these types of prostate cancers, but they're both equally good at treating the prostate cancer. That's the take-home point, and they just have different side effects. So I listed some of them here. We generally talk about urinary, GI, and sexual side effects of radiation. So with the urinary side effects, it's frequency of urination or blood in the urine. GI, it's going to be damage to the rectum behind the prostate. And then sexual dysfunction is going to be ejaculatory and erectile dysfunction. There's always small chances of another cancer forming in the bladder or the rectum, because that's what radiation does. It damages DNA. That risk is very, very low, though. There could be acute side effects. So during the treatments themselves, it's common to experience some of these things, or there can be delayed or chronic side effects of radiation that can happen years later. We'll sometimes see folks 5-10 years after their radiation with bladder problems, bladder bleeding from radiation. So sometimes we'll do hormone therapy with radiation. If you have a certain type of prostate cancer, we'll talk about hormone therapy or androgen deprivation therapy. That's going to lower your testosterone down to an incredibly low level on purpose. That's what it's supposed to do. And with that comes all the side effects of low testosterone. So going through menopause or menopause for men. With that, fatigue is the big one, but definitely loss of muscle mass, increase in body fat, low libido, hot flashes, just like menopause. And then it can affect your bone health. Osteopenia and osteoporosis are very common with hormone therapy. So what can we do about it all? What can we do to reduce these side effects from radiation? Well, if you're having urinary side effects during radiation, you often get put on a medication to help relax the prostate. Flomax help relax the prostate and let the urine get through a little bit easier. I always encourage patients to consult with a radiation oncologist or a team that performs SpaceOAR. This is a gel material you can see on the picture there, a gelatin material that degrades later on after the treatment, but it increases the space and increases the space and makes this buffer between the rectum and the prostate, so that area of high dose radiation is moved away from the rectum and decreases those GI related side effects. Exercise, critically important. This is on this slide, but exercise for prevention of prostate cancer, exercise for survival of prostate cancer can't be overstated. There's plenty of ways that exercise affects your metabolism, your immune system, oxidative stress, the androgen signaling pathways, but it reduces inflammation. And so we know that exercise, particularly focusing on vigorous exercise where you get that heart rate up, not just walking down the street, but walking at a brisk pace or on a bicycle or even jogging, vigorous exercise at least 3 to 4 times a week, that's going to have all these beneficial effects of reducing your recurrence rates from prostate cancer. If you're on that hormone therapy, we talked about loss of lean muscle mass as a potential side effect, and muscle mass is key to longevity in general. So we want to do strength and resistance exercises to try as best we can to maintain that total body muscle mass. With that, of course, comes diet. We want to focus on whole foods, not processed foods, lean proteins, and then plenty of vegetables cooked, when you can, and extra virgin olive oil. That's all been shown to help with almost any cancer. If you're on those hormone therapy treatments, you need to be taking calcium and vitamin D supplements. That reduces your risk of osteopenia and osteoporosis, bone fractures, just stepping out of your car and fracturing your femur. That's what we want to avoid. And then if you have any of those risk factors, either seen on a scan or in your history, we'll send you to a bone health clinic to talk about potentially other treatments to help prevent those side effects. So a lot of things you can do for this. Moving on to surgery. So let's say you're choosing surgery for prostate cancer. Well, one of the main things is going to be urinary control problems. So the muscles that help support the pelvic floor, the bladder, those are intimately associated with the prostate. They're even connected via ligaments to the prostate. So that pelvic floor is going to get weakened from surgery to remove the prostate. And just like a woman that has a baby and needs time to regain the strength and control of those pelvic floor muscles, all men are going to leak a lot of urine right when that catheter comes out, and it takes time and effort to strengthen those muscles. We leave that sphincter, the valve, we leave it alone, but the sphincter is a complex that is part of the pelvic floor musculature. So much of what you're going to be focused on after surgery is restoring the strength of those pelvic floor muscles. So what can you do about it? Well, Kegel exercises. So we'll tell folks to start Kegel exercises. Those are the pelvic floor strengthening exercises. We'll do that 2 weeks prior to surgery. And then, of course, you'll pause when that catheter is in place for the surgery. And then you resume immediately after the surgery. We've got videos on our website that go into some of those exercises. And when we have particularly motivated patients that want to take the extra step, or they're experiencing higher volume of incontinence for a longer period of time, we'll refer folks to physical therapists. There's folks in most communities. In this community, we really like to send folks to Forefront Therapy. They have an excellent pelvic floor rehabilitation program. Busy slide here, but this just kind of goes over an example of how to do those pelvic floor exercises, starting on your back, focusing on the pelvic floor, not contracting other muscles like your legs or your abdominal muscles. And you're trying to do these 30 to 40 exercises a day with different durations, shorter holds, longer holds. And we've got a lot of documentation that we can provide in clinic. And you'll have these slides for reference on just ways to do that. Sometimes it's easier to watch the video, and sometimes it's easier just to meet with a physical therapist in person and have them progress you through a training program and show you all those exercises. The other big potential side effect of surgery is going to be erectile dysfunction. That's shared with radiation. It's just a different time course of how you get there. You're going to have a much more acute loss of erectile function after surgery because those nerves that supply erections, they get damaged. They run directly adjacent to the prostate. And even with the best nerve-sparing prostatectomy, we do that very frequently using a robot, using magnified 10 times X magnification. Even with the best nerve-sparing procedure, those nerves get paralyzed. It's like if you hit your funny bone on the table, except it takes a lot longer. Those nerves get completely paralyzed. So what can we do to preserve sexual function after prostatectomy? We've got penile rehab. So there's pelvic floor rehab. We've got penile rehab. The first thing we start with is a prescription medication, essentially the generic form of Cialis, because when those nerves go to sleep, even if the erections are going to recover later on, when the nerves go to sleep and the erections stop, you get loss of that regular cycling of erections that occurs at night or in the morning or 3 or 4 times a day. And that's the inherent process to preserve length and prevent scarring and preserve blood flow to the penis. And so even with temporary loss of that blood flow, you can get shortening, you can get scarring, you can get permanent erectile dysfunction. So our goal is to try to preserve blood flow, preserve stretch, and preserve length to give you the best possible outcome. So a Cialis daily medication, we'll prescribe that for you. That's just going to promote blood flow to all those erectile parts of the penis. We then would give you a over-the-counter. You can purchase this kind of dietary supplement, L-citrulline, that also improves blood flow through a different medication, different mechanism. And then we also offer or encourage folks to use a vacuum erection device. And this is going to artificially pull blood into the penis. And that can really help preserve those stretchy fibers of the penis that are inherent to proper erectile function. So with the vacuum device, again, we've got information on how to use that and where to purchase that. But it's all kind of third-party purchased it. You're going to essentially want to inflate that until it's uncomfortable and hold it for about 10 seconds and then deflate it. You're going to do that about 10 times in a row, and you would do that at least once a day, but up to twice a day. Mindset for all of this cancer journey. I'm just going to touch on this briefly because it's something I hear from patients all the time. The surgery was hard, radiation was hard, but what I didn't expect was how this was going to affect me mentally. Because sadness, hopelessness, fear, frustration, anxiety, they're all incredibly normal emotions after a prostate cancer diagnosis. particularly with something that's so sensitive. We're talking about urinary control, sexual function, erectile dysfunction. It's very relatable to breast cancer, where something that's so important to femininity. This is something that's so important to manhood. So patients tell me they feel a sense of loss of wholeness or manhood, and it's not necessarily at all about the sexual function or sexual performance. It's just the mental toll that takes on you. And so just knowing that that's normal, that there are options, staying positive, trying to prioritize diet and exercise like we talked about, being very proactive in your rehab. These are going to be very important to maintain control of that proper mindset. So then let's say for a second that despite all of that, despite all of your best efforts and the best surgery with the best folks or the best radiation with the best folks, still dealing with some of these nasty side effects, because that's common. This is in particular for incontinence. I think I'm a pretty good surgeon, but I'll tell everybody there's about an 8 to 10% chance of long-term persistent problems with incontinence. And that's true across the country, no matter who is doing it. Sometimes time can help. Sometimes physical therapy, like we talked about, can help. But we have other options if that remains persistent and severe. As early as 6 months after the surgery, there are options to help restore continence. It's not something that you have to live with just because you've had prostate cancer. So some other things you could do, there's pads, of course, that depends. There's different kind of urine collection device called condom catheters. You can even purchase a clamp that sits around the penis and clamps the urethra from the outside. That can be quite uncomfortable. We talked about physical therapy. But then we have surgical options as well. So the most common procedure I perform for incontinence after prostate surgery is going to be a male sling. It's a simple, quick outpatient procedure with a few small incisions. We're essentially mobilizing the urethra, pushing it into a new location where it restores continence and compressing it up against the pubic bone. And most patients go home that day and see immediate improvement in their continence. The other option, I should mention the sling is going to be for men with mild to moderate incontinence. And that's something we would talk about in clinic, but you think of it kind of as maybe up to 4 pads fully saturated in a day. So that's a lot of incontinence. But if you're someone who is going through 8 and 10 depends per day, you're not spending that much time in the bathroom because you're mostly leaking, the sling may not be the right option for you. And that's where an artificial urinary sphincter can be a better option. That's for moderate to severe incontinence or people with especially difficult anatomy. So I'm just going to let this video play. But that's a little bit more of an involved procedure. It's got several incisions. It's got 3 components to it. It's an inpatient procedure generally when I do it. And so we'll keep you in the hospital for a night. But there's these 3 components. There's this bulb that sits down in your scrotum. There's an artificial sphincter that sits around the urethra and a balloon up in your belly. So when you want to pee, you press on that bulb. It relaxes the sphincter, and then the urine can get on through. About 90 seconds later, that sphincter will automatically reinflate, and that would restore continence. So it's a really fancy device. It's been around for a long time. We still do that frequently for people with moderate to severe incontinence. And so it can be a good option for you if you're experiencing that. Again, not something that you have to live with. Then let's talk now about restoring sexual function. So as we talked before, erectile dysfunction almost universal in men after prostate cancer surgery. Even with the best nerve-sparing procedure in the best hands, still about 40% of men are going to have permanent severe erectile dysfunction, and there's things we can do about that. I want to touch briefly on just ED in general, because in the total population, it's incredibly common. 1 in 5 men, almost 40 million American men have some degree of erectile dysfunction. If you live long enough, it's just going to be something that you experience. This just kind of goes briefly over the erection process and how that works. The blood goes in, it has to stay in and not leak back out. That's essentially how an erection would work. And so things that we've talked about before are aimed at improving blood flow. So things that impair blood flow are going to be another risk factor for ED. So if you have prostate cancer and diabetes, or you have prostate cancer and cardiovascular disease, you're going to be at much higher risk for permanent and severe ED after one of these treatments. Diabetes, incredibly common. So many men with prostate cancer also have diabetes. The ED is going to be more severe, and you're less likely to respond to oral medications if you have that diagnosis as well. Why? Because it affects blood vessels and nerves. Not surprising, it's what we've talked about already, but just like the nerves and blood vessels to your fingers and your toes get affected by diabetes, the same blood vessels get affected that go to your penis. Heart disease as well. Cardiovascular disease is an incredible risk factor for ED. We kind of think of it as the canary in the coal mine. So if you have a new diagnosis of cardiovascular disease, you're much more likely, if you have a new diagnosis of erectile dysfunction, you're much more likely to develop cardiovascular disease than someone who doesn't. Why is that? It's because those arteries are affected. So the atherosclerosis, the plaques that build up in arteries, they would first affect the smaller arteries first. So the penile artery is smaller than the coronary arteries, and so they get affected first, and you can see it before it affects your heart. So what can we do about it? Well, we talked about medications already. We talked a little bit about vacuum erection devices. I'm going to touch on the rest of these. So injection therapy, that can be very helpful. We can do that essentially right away once your continence improves. This is going to be an injection directly into the penis, within 30 minutes of you actually wanting an erection. So every time you want an erection, you have to inject this medication directly where the blood flow needs to start. It's going to be stored in a refrigerator. Obviously, there can be some pain and discomfort with that. I have some patients that really see benefit into this, and it's how they manage their ED. Most men are not going to use it long term. Probably only about 20 to 40% of men would continue to use that at the end of a year. But right away, restoring sexual function, it can be very effective. These urethral suppositories, that's again delivering the medication to where it needs to be. I have fewer patients using that, but it is an option, a non-surgical option. Kind of burning with urination or problems with blood pressure are going to be common with this treatment option. The last thing I want to talk about, though, is a penile implant, because that is something that we're increasingly utilizing to restore sexual function. We know the more people know about this before treatment for prostate cancer, the more we can kind of try to prioritize sexual function after prostate cancer. This is going to be, there's kind of 3 different devices, but we essentially use a 3-piece penile implant most commonly. And I'll start this video here. So it's outpatient surgery, small incision in the scrotum. We're going to put these 3 components directly in through that small incision. And so you'll have a pump that sits down in the scrotum. When you want an erection, that's going to move fluid from a reservoir that you can't see up in your belly into these cylinders that replace the normal erectile bodies of the penis. So now instead of filling with blood, those erectile bodies would fill with saline from this device. It would last for as long as you want and stay as rigid as you would like it. And then when you want the erection to go away, you press on the button on that little bulb, and the erection goes away, and no one would even know that you have that device. So we said small outpatient procedure, so small incision, take usually 1 to 2 weeks off of your regular routine and minimize your activity, and then 4 to 6 weeks of healing before we'd actually teach you how to use it. So it's something that's very common. Probably 1 million of these have been put in the United States. We do them all the time around here. I'm one of the higher volume penile implant surgeons in the state. Why do we like it? Because this is a proven and effective and permanent treatment for ED. There's no more fooling around with medications or injections. It's discreet, it's reliable, it allows for spontaneous return of sex to your life. Of course, there are small risks. We would talk about those in clinic, but risks of pain, risks of infection, risks of bleeding, and risks of device failure. The important point that I always make is it's not a lengthening procedure. We don't have any procedures that are going to lengthen your penis. And people experience, as I mentioned to you, loss of length over time with erectile dysfunction. So the earlier we intervene, the better. The more you can do to preserve length after a diagnosis of prostate cancer, the better outcome you would have with a restorative procedure like this. It's covered by insurance companies. Most companies are very good at covering this. We work with insurance companies all the time. We would even get that prior approval even before your appointment. So again, just to kind of summarize, it's a very common problem. It's not often only related to prostate cancer. It can be associated with other conditions. We've got a lot of different treatment options for it, from medications all the way to this implant as the most permanent and from a patient satisfaction standpoint, statistically, is the best option there. So you'd want to talk to your partner about that, and if you're at all interested, you come see us. So we went over a lot of things today. I'm going to look here and answer any questions that folks have. Talked about the different ways that prostate cancer can affect you, the different side effects from prostate cancer treatments, the things that we can do about that, the things that we can do to lower the impact of those side effects. We talked about when they're persistent and severe, we do have options. So if you're interested in some of those options because you've tried the other things, you can reach out to that number, schedule an appointment with me. If your insurance company needs a referral, your PCP can make that referral. If you're specifically interested in any of those continence procedures, the male sling or the sphincter or a penile implant, we're going to send out a separate link with a reminder and a link to dedicated appointment slots. And so that's where we'll know you're coming in for that discussion. We can be prepared with insurance prior authorization, so you know what your cost would be. We can be prepared with demos and things like that. And then the last are just some references. So we'll be sending out this slide deck later, but let me look here and see if there's a way for me to see what the questions would be. Stop sharing. Okay. Okay, so let me see if there are any questions that are coming through. I don't see any. Okay, so we're not seeing any questions. These are anonymous, so you don't need to be fearful that other people are going to see it. That's why we hosted this webinar instead of in person, so that you can do this from the comfort of your couch and not have to be fearful of any of that. Let me see. I think there might be one that's coming up here. Lymphoid infiltrate, the same as BPH. I think that's a question. Let me be honest, based on what I'm reading there, I'm not entirely sure what that refers to. Probably a pathology report, and then we would need to see the whole pathology report to understand what they'd be referring to there. But a lymphoid infiltrate is I'm assuming most likely going to be some sort of inflammation, which would be a common report on a prostate biopsy, just like a BPH, which is that non-cancerous growth of the prostate. That would be a common report on a prostate biopsy or any form of prostate cancer. That's what those biopsies are done for. Send in a request for pre-surgery meds on my chart. Okay, we'll look into that after this webinar and see what we can do about getting those for you. But we are, with this webinar, I'm creating a big packet of information to be given to patients at the time of surgery or the time of scheduling surgery, so that all this information is kind of codified for you, where to when and how to take these medications, about the penile rehab, about pelvic floor physical therapy, where those referrals go, how often to do everything. That would be really nicely spelled out for everybody. Okay. Well, if there's not any more questions, we'll probably just wrap it up a little bit early here. Let's see, there might be a few more here. Okay, what pain meds will you be on after prostatectomy? We generally will use a narcotic type pain medication like oxycodone or Percocet. And sometimes non-narcotic medications like Toradol, and then definitely Tylenol and Advil if you're not on Toradol. Can you do both the AUS sphincter and penile implant? You can get both of those procedures, yes. We don't do them at the same time because there's higher risks of infection when you do both the sphincter and the implant at the same time. And then if one got infected, they both have to be removed. So we would stage them generally on which one of those things is most bothersome to you. And then that way, once you've healed up from one, if the implant or the sphincter got infected, in the very, very rare scenario that occurs, you could potentially still salvage one of those devices and not have to remove both. So those are kind of the reasons why people always ask, why can't we just do them both at the same time? The standard is to stage them. What is the normal time dealing with incontinence before seeking additional help? Previously, it was taught to me we would wait a year to do any sort of surgery, but recently the guidelines have been revised that we will intervene even sooner, as soon as 6 months. So I'll see somebody back 6 weeks after surgery, and if they're still dealing with significant incontinence at that time, we talk about physical therapy as absolutely the immediate next step. And then sometimes time, upwards of a year, I see patients that had high volume leakage at that 3-month, 4-month appointment. And then by a year, they're really doing so much better. So everybody's a little bit variable. It can take time. But for people with severe incontinence, and it's 6 months and they've tried physical therapy, we're going to definitely start to talk about those surgical options if you were interested. Okay, let me look here. What length of time is required to maintain a low PSA until prostate cancer is considered to be in remission? You know, when that PSA is undetectable after surgery, we would definitely consider the prostate cancer to be in remission. After radiation, it's not exactly black and white. You're going to see a much lower drop, or you're going to see that PSA drop to a much lower level, and then you follow it from there. But the longer that time goes by, the lower the statistical chance that you would ever have a problem with prostate cancer. So 2 years, that risk is quite low. 5 years, it's very, very low for you to ever have a problem with prostate cancer. Again, if your PSA remains undetectable. At 10 years out, it's almost unheard of for someone to have a recurrence of prostate cancer. Of course, there are always outliers there. And yes, I've seen, prostate cancer recur that far out, 10 years out. Very, very uncommon. Don't want anybody to be worried about that, but it's just important, to always follow the PSA after a diagnosis of prostate cancer. It goes from being a screening test, like we talked about. At that point, it becomes a tumor marker, and so that's how we would do that. Okay, let me see. Are immunohistochemical studies always done with biopsy? That I think is referring to essentially just the pathological analysis of biopsy tissue. Yes, that they're going to stain it. They're going to look for various receptors that are overexpressed. I'm going to make a fool of myself if I try to explain it in too much detail, because that's an entire practice of medicine, is pathology. We have very experienced pathologists at Deaconess who deal with prostate cancer all the time. But yes, they do immunohistochemical stains on all of their prostate biopsy specimens. If there's any concerns, we'll often talk about folks at multidisciplinary tumor boards, where we get pathologists and radiation oncologists and radiologists together if there's a complicated case. If there's concerns about the slides, we can always send them off too. Sometimes we'll send slides off to Mayo or other places to get some super specialty expertise. After the catheter removed, how long does it take to have a good urine stream? Typically, after a catheter is removed for after prostate cancer, you're going to have a pretty solid stream. Sometimes there can be a little bit of swelling in the urethra that is restricting that flow slightly. You should still be able to empty your bladder well, but that usually goes away within a week or two. But most people are dealing with a stream that's kind of too good. It's incontinence. If it's mostly incontinence that you're experiencing, though, then your bladder's just never going to get full enough to experience that strong stream. You have to have a distended bladder for it to get a good contraction, to get a forceful contraction to produce that kind of solid, normal urine stream you're accustomed to. Are those numbers better once removed in regard to remission? I think that's referring to, if I'm reading that question correctly, what's going to have a better chance of remission, radiation or surgery. And that's where, as best we can tell, for certain types of cancer, if you combine the radiation with the hormone therapy, you're going to get the same outcomes in terms of cancer control, chance of remission, whether you do radiation or surgery. So in most circles, we think of these treatment options. It's a little bit nuanced, and it depends on the stage and the grade and the how spread out the cancer might be. Is it surgically resectable? Is it in the lymph nodes? There's a lot of things that go into that assessment. But for localized, intermediate or localized high-risk prostate cancer, the oncologic outcomes are going to be similar. So we're getting a few more questions here. I'm going to see if any more come in, and then we may look through these and send out a bit of blurb, via email later on as well, so that we can respect everybody's time here. Okay. What is considered an undetectable PSA value? You're going to see less than 0.01. That's usually how it's reported. So it won't say undetectable. It's a little less than sign and then usually 0.01. And that's when I say undetectable, that's the value that I'm actually referring to. It's been 15 years since my prostatectomy. PSA has been undetectable since. I'm continuing PSA testing. You can, the chance, again, statistical chance that you would ever have a problem with prostate cancer is infinitely small. But if I had a history of cancer and I have a simple test that can detect recurrence, I'm going to include that in my yearly blood work. There's nothing more that you would need to be doing from a cancer monitoring standpoint, though. Why do I only leak when I stand versus lying down or sitting? That has all to do with that pelvic floor muscle. So when there's not much pressure, intra-abdominal pressure on that pelvic floor when you're sitting or you're lying down, then it doesn't take much pelvic floor tone to maintain your continence. And so it's when you stand up and you increase the intra-abdominal pressure and the weight and the amount of energy required to maintain that pelvic floor muscle tone. You increase the intra-abdominal pressure that is directly transmitted to the bladder, and that pressure has to be withheld at the level of the pelvic floor. That's when you're going to leak, is from that. So standing up, climbing into a vehicle, pulling yourself up, so increasing your abdominal pressure there, any sort of heavy activity is when people will leak as well. Okay. I think that's about it here. So We will send out the presentation later on, and if there's any more questions that trickle on in, we will do our best to answer those later on. But I hope you all found this informative, and like I said, we'll be sending some information on those appointments if at all interested. All right, take care.